Welcome and thank you for coming. This is the Titin subtype breakout for talking about care for people with Titin-related muscle and heart disorders. Thank you so much for being here today. I'm just going to start by reading a quick disclaimer, and then this is the care breakout disclaimer. The information and opinions shared by our panelists will be generalized statements and are not intended to be interpreted as medical consultation or substitution for medical care. Please consult your local healthcare providers regarding any specific health-related concerns. Also, this session is being recorded and will be shared on our public YouTube channel after the conference. Portals closes on at the end of August. So thank you. And I didn't introduce myself. I'm Sarah Foy from Team Titin. And I would like, if you could, all the panelists introduce each other. We could start with Dr. McNally.
Hi, I'm Beth McNally. I am at Northwestern University Feinberg School of Medicine in Chicago. I'm a cardiologist. I'm an adult cardiologist, and I take care of a lot of neuromuscular patients and their cardiac complications. And I lead our Center for Genetic Medicine at Northwestern.
Great, thank you. And Dr. Meyer?
Yes, I'm Hank Meyer. I'm a pediatric pulmonologist at the Children's Hospital of Philadelphia, and have had a longstanding interest and opportunity to manage patients with a variety of different neuromuscular conditions, and have a very small but proud group of Titin patients.
Oh, fantastic, thank you. And Dr. Sarkozy?
Hello, good morning, everybody. I'm Anna Sarkozy. I'm a clinical geneticist and neuromuscular consultant working at Great Ormond Street Hospital in London, in the UK, and we are a reference center for the country for congenital myopathies and muscular dystrophies, and we look after a number of patients and families with this condition.
Great, thank you. So I just wanted to let the attendees know that if questions were submitted in advance and they were provided to the speakers, and they're going to incorporate them into their talks. And each of the speakers are going to talk for a few minutes, and then we'll have a short Q&A at the end. If you have questions, you can put them in the chat. Okay, fantastic. So I'm going to turn it over to Dr. McNally. Thank you.
Great, thanks, Sarah. Let me get the screen sharing up and going. And hopefully that works and people can see that. So I'm going to just talk a little bit about taking care of your heart. Some of my comments are going to be more broadly in the context of neuromuscular disease, but then I'm going to specifically call out Titin because that's part of what we're doing here. So just to point out, there are a number of neuromuscular diseases that have cardiac involvement. And what I highlighted in red here are the ones that can be associated with Titin mutations. So we know in some settings, Titin mutations can lead to LGMDs, both dominant and recessive, and in that context be associated with both skeletal and cardiac involvement, and the same can be said for the congenital myopathies. So part of the challenges of working with Titin is that Titin mutations can really present across the lifespan, where much of the discussion in this meeting has been around the younger set and presenting as children, but we also know that there's parents who may have a single copy of those Titin mutations and then therefore have some cardiac risks themselves. So I'm going to try to cover that lifespan discussion. A key thing to just keep in mind here is that the heart is a little bit different than skeletal muscles. Smooth muscle shown over here is what makes up and contributes to the gut and the arteries. The heart, but these do all look a little bit the same. The heart has both atria and ventricles, and those are both different from each other. And even the right and left ventricle are different from each other. And then skeletal muscle is different. And the way Titin mutations can affect heart and skeletal muscle can be different. So many of the adults that I take care of with Titin mutations really just have cardiac involvement, and they don't necessarily have skeletal muscle involvement. But again, it's highly dependent on what the specific mutations are, whether they have 2 copies or 1 copy of the mutations. So just broadly to talk about cardiomyopathy subtypes, the normal heart has the 4 chambers, right and left ventricle, and the right and left atria. Dilated cardiomyopathy refers to the heart being enlarged, especially the ventricles, and typically having reduced function. And so sometimes you will hear a cardiologist call that HFrEF, which is heart failure with reduced ejection fraction. And then hypertrophic cardiomyopathy is a bit different. Usually the function of the heart is maintained, but the walls of the heart can be thickened. Occasionally you'll hear people refer to things called HFpEF, which is heart failure with preserved ejection fraction. And that's somebody who has heart failure, but the heart function actually looks okay. What we know if we look at limb girdle patients, and this probably didn't have quite the representation of Titin patients in it that it might, hard to say, but we do know that Titin is one of the limb girdle dystrophies that definitely can associate with cardiac problems. And so a key take home message, hopefully everybody on listening knows, very important to know what your primary mutation is, because it really dictates what the risk is for your heart. And so that's message number one, which is know what your gene mutation is specifically. So what we know in the adult situation, so one of the tricky parts of Titin is that Titin truncating variants are present in about 1% of the population. And so when I say that, I'm talking about people who have this heterozygously, meaning we have 2 copies of Titin, one from mom, one from dad. And if you have a premature truncation on just one of those copies, that's a heterozygous situation. And if we look in some of the large databases, for example, EXAC or NOMAD, which is what we look in these days, those are large collections of sequences on many different people, we see that Titin truncating mutations can occur anywhere along the length of the enormously long Titin gene. What's cool about this study is this is called which parts of this PSI means which parts of the RNA are included in it. And so for what you'll see for Titin is many of these middle parts are not actually expressed in the hearts. And so the mutations really do have to fall within these dark blue areas to be causative of heart disease. And so across these 2 large databases, their patients with cardiomyopathy were more likely to have premature stop signs more towards the end of the gene, but they also had individuals who had it at the first part of the gene as well. And so initially there was a lot of discussion that if those premature truncations were falling here in the beginning part of the gene, maybe they weren't so pathogenic. We don't actually think that way anymore. So basically a Titin premature stop sign can occur pretty much anywhere along the length of the gene and carry some risk for developing heart disease over time. This is an interesting, this was from that same paper. And what they did in this group was they looked in there, they had a lot of people who had undergone sequencing. So they knew people who had Titin truncations. And they said, what clinical diagnoses do we see enriched for those people who have Titin truncating variants? And overwhelmingly, you see those answers are really cardiac conditions. So most likely these individuals were going to carry a diagnosis of cardiomyopathy. Some had defibrillators, paroxysmal ventricular tachycardia, heart failure, but you see the great spectrum of things that can show up for individuals who have Titin truncating mutations. Now, this is almost all adult patients. So again, this is speaking to those individuals who have one abnormal copy of Titin, where over the lifespan, you do carry an increased risk of cardiomyopathy and irregular heart rhythms. And so since we can know that information in advance, the question becomes, what do we do to better take care of that situation? So this is message number 2, this is from the American Heart Association, which is Life Simple 7. These are the general recommendations of what to do to take care of your heart. You want to eat healthy, watch your weight, exercise, which if you have neuromuscular disease is pretty darn difficult to do. But then also those simple things of don't smoke, manage your blood pressure. And I want to emphasize this because managing blood pressure is some of the reason why we use early medical management for patients, manage cholesterol and blood sugar. And I'm going to add Life Simple 8 to this right now, which is get vaccinated for COVID. It's very, very protective. We know people with heart disease are at increased risk of COVID complications. You definitely want to get vaccinated. I know there was a question coming in, what do we know about vaccination for example, in the neuromuscular population? I just want to mention I've been involved in a small COVID study asking the question of whether vaccination is effective in people with neuromuscular disease. Some of you know the new COVID vaccines, the mRNA vaccines. We get injected in our muscle. And so it's a very natural question that if you don't have that much muscle mass, do you properly develop an immune response to these new vaccines? And so we've been doing a small study, and I'm pleased to say that the first patients we've looked at from a spectrum of neuromuscular diseases seem to have a very nice, robust response to the vaccine. So, so that's just a little bit of additional information. So cardiomyopathy is when the heart appears abnormal. but heart failure is the symptom that may develop from that. And heart failure is really a symptom of inability to do things and feel shortness of breath and fatigue. And in the setting of neuromuscular disease, the real complaints may just be fatigue. And the second part is that irregular heart rhythms can be part of what happens in the setting of cardiomyopathy. So that's the other thing that we look for. So how do we monitor the heart in neuromuscular disease and those who have Titin? So again, number one, know your gene. And then we do a smattering of ways of looking at the heart. We do echocardiograms, usually once every 1 to 3 years, EKGs, which once every 1 to 3 years, a Holter monitor, which I'll talk about in a second, and then MRIs, which help us actually see a lot of consistency of whether there's scarring in the heart and things like that. We'll hear about shortly some of the respiratory care management, which is really important, and how to do that. And then I just want to emphasize, we do have some very good blood tests to look for more subtle changes in the heart. Troponin can be used to look at for injury to the heart, which we know in the case of genetic cardiomyopathies, you can have increased troponins over time. BNP, or brain natriuretic peptide, there are sensitive assays for this. These can be blood markers for heart failure. I find this super helpful in the neuromuscular patients. And then of course, the more common things, which is make sure your cholesterol is in good shape, know your A1C as a risk for diabetes. And then we use this cystatin C to monitor for people who have neuromuscular disease and whether they might have kidney failure. So that's another helpful marker. Echocardiography is the mainstay of how we look at the heart. There's, I know it often looks like weather maps when you look at what an echo looks like, but trust me, it really isn't a weather map. We have a very consistent set of views that we take on the heart that follow the same order, and we can see the 4 chambers of the heart and see what its function is. This is ultrasound. It is very safe, and we can use contrast, but the contrast here is a different kind of contrast. It's just little bubbles, and it doesn't let us see what the tissue of the heart really looks like. We use cardiac MRI because this lets us know what the tissue looks like in the heart. It gives us information about scarring or inflammation in the heart, as well as very careful measurements. Not everybody can do an MRI. It can be a little claustrophobic for some people. You have to be able to hold still to do it. You have to be able to follow commands, hold your breath. You can't have metal in your body. So if you have an ICD, that can present a complication. It just requires extra care to do that. And then the contrast that we use in MRIs is something called gadolinium. So it's different than the contrast that we use with echoes. We also monitor the heart rhythm. We heard about this a little bit earlier today in the Lamin session. The heart beat starts up here in the right atrium. It travels through the atria to the middle part of the heart, or the AV node, and then goes down through the ventricles. And we can see those parts of the conduction system, the electrical conduction system, on the surface EKG. But we also have more sophisticated ways of looking at that. The EKG, you get the leads put on. We look at 6 seconds of your heartbeat, and 6 seconds isn't a very long time, but it does give us some good, quick baseline information. The other ways we look at the heart these days are to use heart rhythm monitoring. And these days it's mostly done now with these patch monitors, which you can wear for up to 14 days, and they don't have all the wires sticking out of them. And you can shower and bathe with these. And so we have switched to using exclusively patch monitors now to monitor the rhythm. What can you do to monitor yourself? Well, the smartwatches have gotten really good these days. Both, well, I should say all 3, Fitbit, Google, and Android and Apple all make very good smartwatches these days that can give pretty decent tracings that are very accurate for picking up atrial fibrillation. I use them with a lot of my patients. There are other devices you can stick on your phone to do like a mini EKG. And then there are more simple just heart rate monitors that will just give you the rate of the heart. But increasingly, I have a lot of my patients wearing these smartwatches and getting a lot of good information from that. We have a lot of medical treatments for our patients. You will hear cardiologists use terms called GDMT, that is guideline directed medical therapy. That involves an ACE inhibitor or angiotensin receptor blocker, a beta blocker, and then a series of other drugs. And I'd like to point out this because this is relatively, well, actually both of these are relatively new. Neprilysin inhibitors, or Entresto, you see a lot of ads for that, or SGLT2 inhibitors, which are treatments for diabetes, but have in the last year been shown to be really effective for heart failure. And so I'm particularly interested how these do in neuromuscular patients. But a lot of our patients, and I want to emphasize this, we want to treat early. We want to start ACE inhibitors and beta blockers early in our patients before the heart gets bad and not wait until the heart gets bad. So that's the mainstay of what we do with treatments, which is to treat early and to control blood pressure and to make sure things are in good shape. Advanced treatments are also available where there's increased risk for atrial fibrillation. Again, that monitoring can be really helpful. Anticoagulation. We also have a whole slew of devices that we use to treat the heart, defibrillators, pacing, and loop recorders, which are like those patch monitors, except inside the skin. We also have many advanced options for treating the heart, infusion therapy, and assist devices, and even transplant. And so here's the high-level conclusions, which is know your gene and mutation. The heart can and should be treated early. Don't wait for the heart to get bad. Manage blood pressure and cholesterol and don't smoke. Certain genes have a high arrhythmia risk in the LGMD space, and that's Lamin and Desmond, FLIN-C. We don't specifically think of Titin as having a higher arrhythmia risk, but mostly that it has risk, but not an especially high arrhythmia risk. And your cardiologist should be very aware of what your mutation is and what your risks are, and be willing to work with your pulmonary and neurology team. And so with that, I'm going to stop there and pass it off to the next speaker.
Dr. Meyer, you're up. Thank you. Okay.
And you'll need to unmute.
Sorry about that. So I'm going to go through a very brief overview of the pulmonary issues that occur in just general neuromuscular disease, and then the options that we have for management. So with any neuromuscular condition, and certainly Titin is not unique, we start with respiratory muscle weakness, and then the end point of the progression is respiratory failure, where patients unable to effectively bring in the oxygen needed and remove the carbon dioxide that the body produces. There are a number of different pathways along the way. There are three. The first, and I think arguably the most important, is through diaphragm weakness, the diaphragm, of course, being the primary respiratory muscle. And then the chest wall has a muscle that helps to provide support between the ribs and connecting to the spine, and the spine, of course, providing the capacity to maintain an erect and ideally fairly straight up posture. There's a lot of interplay between all three of these pathways. If we look over to the left between the diaphragm and the chest wall, if there's dysfunction, then that can lead to pretty significant poor airway clearance, which puts patients at risk of developing lower respiratory tract infections such as pneumonia. And then having an acute infection can lead to further weakness, so further diaphragm fatigue, and then the debris in the airway, secretions and inflammation can lead to narrowed airways and increased respiratory load. And then if we look at the chest wall, initially even a weak chest wall, because of underuse of respiratory muscles and atrophy leading to fibrosis, can eventually become stiff. And a stiff chest wall is very hard to move during breathing. In addition, the spine, when there's poor core muscle strength, can begin to tip either forward, which we call kyphosis, or from side to side, which we call scoliosis. And that, in conjunction with a stiff chest wall, can lead to external restriction of the lungs and low lung volumes. The lower the lung volumes are, the narrower the airways are, and the narrower the airways are, the higher the load on breathing is, the harder it is to breathe. And so ultimately, we get down to a balance between diaphragm strength or fatigue, and then the load that's required for the diaphragm to breathe against. And if the load cannot be overcome by the diaphragm, or can't be overcome on a consistent basis, then we have respiratory failure. There are a number of different interventions that we have, two of which that we'll talk about. The first of them is poor airway clearance. We have ways of assisting with airway clearance. And then our orthopedic colleagues can be very helpful in providing external bracing, or doing a surgical intervention to correct kyphoscoliosis. And of course, we have ventilatory assistance that we can offer to help treat respiratory failure. And then our basic science colleagues, and some of whom have presented their data yesterday and earlier in the conference, are looking at ways of doing very upstream management and preventing respiratory muscle decline. Whoops. So let's talk about airway clearance. And before doing that, it's important to talk about what's involved in a cough, and then how can we help support what may be deficient. So the cough, the first phase is, of course, taking a nice big deep breath to fill the lungs up and get air behind secretions. And then you cycle quickly into a compressive phase where you're beginning to breathe out, but right at the early phase for about 1/4 of a second, the vocal cords close. It's completely subconscious, happens automatically. And during that time, when you're exhaling against a closed glottis, pressure builds up in the airways, the respiratory tract. When the vocal cords open, you get an explosive flow of air up the respiratory tract, similar to taking your fingers off a balloon after you blow it up. That explosive flow of air brings airway debris, mucus, and other things up to the more central airways, from which the patient can then expectorate. Oops. So there are a number of different ways that we can compensate for this. The first being helping a patient breathe in more deeply, so helping with inspiration. We can then help a patient breathe out more forcefully, and we can then do both inspiratory and expiratory assistance together. In addition, there's some accessory techniques and devices that we can use on top of inspiratory and expiratory assistance. And there's some medications that we can use to help with airway clearance, but we won't really get into either of those during this talk. So for inspiratory assistance, on the bottom left, there's a device there that we call a breath stacking device, which has a mask that goes over the mouth and nose. The right circuit, which has a red arrow on it, allows air in through a one-way valve. So the patient breathes in, and then the portion of the circuit to the left has a high pressure pop-off valve that doesn't allow a patient to breathe out unless they breathe out very forcefully. And so that allows the patient to hold air in their lungs and progressively breathe up to as high a lung volume as they can bring into their lungs. The mask is then removed and the patient breathes out forcefully. The device at the bottom right is something called the Alpha 200, which is a device to apply pressure on inspiration to help a patient breathe in more deeply. We call that intermittent positive pressure breaths. The Alpha 200 is quite commonly used in France and some other European countries. The device in the middle is called the Cough Assist, in which you can also apply a positive pressure to help a patient breathe in more deeply and then have them breathe out more forcefully. Or you can use the mechanical insufflator, exsufflator, or Cough Assist to do both inspiratory and expiratory assistance by setting a pressure that's applied to the patient to help them breathe in more deeply, and then cycling to a negative pressure suction to help them breathe out forcefully. With any device, it's important to have a trained therapist to help the patient, help identify what settings would work well for the patient, and most importantly, to teach the patient and the caregivers how to properly use the device. So I want to move on to mechanical ventilation. So when a patient is identified as having respiratory failure, perhaps from a sleep study or other clinical assessment, then we have to set up a way of providing ventilatory assistance. There are two main components to this. The most important by far is the interface, which obviously is how the air gets into the patient. The most common interface for nighttime use is a nasal interface, either through a cannula type interface that goes into the nose very shallowly, or a nasal mask that goes over the nose. For daytime support, there are oral interfaces, and then there are actually oronasal interfaces, so going over the nose and mouth, that can be used at night for patients who have trouble keeping their mouths closed. We can also ventilate through an artificial airway, chronically, such as a tracheostomy tube, or acutely, such as an endotracheal tube. Then there also are some external or full or partial body modes of ventilation, similar to the old iron lungs that we can use. There is a device called a cuirass or a chest shell that can be used as an outpatient. It looks literally like a large turtle shell that's placed over the chest and abdomen that helps a patient breathe in more deeply. The ventilator itself, almost exclusively outside of the hospital and doing non-invasive support, is a pressure ventilator, in which a pressure is applied to the airway opening, helping a patient breathe in more deeply, and then it cycles to a lower pressure, allowing the patient to breathe out. Volume ventilation, which is similar to essentially administering a set volume like using a large syringe, is only used on invasive ventilation, meaning through an artificial airway. There are a number of different interfaces that can be used, and these are interfaces that were current about 5 years ago. The two general categories are silicone interfaces, which are on the top row. And then there are some gel-filled interfaces that can be molded to the contour of the face around the mouth and nose. One of the biggest challenges has been in pediatrics finding interfaces that are small enough and are frankly comfortable enough to use in young children. There are some pediatric specific interfaces such as this one, which can be used, and obviously this young child is quite happy, at least at this point, with the interface. And this particular interface has been a quite widely used one. But ultimately, what has to happen is having somebody that has access to a wide variety of interfaces work with the patient to find one that works and is comfortable. Because if the interface is not comfortable, then the patient's going to simply take it off at night and ventilation won't occur. So there are other interfaces. The one on the left is an oral nasal mask over the nose and mouth. This is often used acutely during acute respiratory failure as a and to try and prevent the need for invasive ventilation. Can also be used if the patient can't keep his or her mouth closed at night because of maxillary and mandibular muscle weakness. The device over to the right is a full face mask going over the nose, mouth, and eyes. And even though it looks a bit odd, this device is actually fairly well tolerated in some patients and is a completely legitimate way of providing support. For oral ventilation, called SIP ventilation, SIP and puff, or mouthpiece ventilation, this device is used. There's a mouthpiece way up at the top of the image that goes into the patient's mouth, and the patient can either keep it in his or her mouth or have the articulating arm hold the interface just to the side of their mouth. And so all they'd have to do is rotate the head slightly, put their lips around the mouthpiece, and breathe away. Alternately, patients that have upper extremity muscle function may opt to use an interface without the articulating arm that they can keep on their lap and then can raise to their mouth when they need to breathe. There are two different types of ventilators that we can use. There are ventilators that are just made for nighttime use that are less expensive than these two ventilators, which are used for continuous use. The nighttime use ventilators do not have engines or pumps that are equipped to be able to provide continuous use. And if used in that manner, they'll burn out eventually. So the solution for continuous use, meaning daytime and nighttime, is to have a continuous use ventilator, or at least have two partial use ventilators that can be cycled between. And whoops, I just want to briefly review general progression. The data here is from Duchenne muscular dystrophy. And I use this as a backdrop just to point out that with loss of respiratory capacity in whatever value you use, such as at least here vital capacity, there are a number of different clinical thresholds that are crossed. First of which is seeing increased respiratory illnesses, illnesses lasting over the typical 7 days, perhaps up towards 2 to 3 weeks, and then leading to illnesses that can't be managed as an outpatient or require hospitalization. And then once you drop below the vital capacity threshold of about 50% predicted, there's an increased risk of nocturnal hypoventilation. And then as the lung function gets down into the 30s, we often see daytime or diurnal hypoventilation. And then to partner with this, there are a number of different studies or interventions that can be done. When we see an increase in the duration or severity of respiratory illnesses, we will provide assisted airway clearance using something like the Inexiflator or cough assist as needed, and then eventually moving to daily use. When the vital capacity drops below 50, many people will go ahead and start to get screening sleep studies to evaluate for nocturnal hypoventilation. And when that occurs, then we provide nighttime ventilatory support. And then when there's evidence of daytime hypoventilation, high carbon dioxide, then we offer mouthpiece ventilation for daytime use. So to finish up, I just want to go over a few points that I think are quite important. Whether you have objective lung function to follow or not, the most important thing is to recognize deterioration, whether it's chronic or acute, and then act. At least acutely, the most important thing is to have an effective plan for doing airway clearance, bearing in mind that when those of us who have intact respiratory muscle strength get sick, somebody else knows that we're sick because we start coughing, and that's because there's mucus to clear. The problem is that if you don't have the ability to cough effectively at the beginning of a cold, if it's not recognized, then mucus starts to accumulate to the point where then it becomes quite evident that something's wrong, and the illness then will be of longer duration and more severe than it would have been if airway clearance had been started earlier on in the development. And so that requires having assisted airway clearance available. And then when a patient has hypoventilation, having ventilation support available non-invasively. And the final thing I just want to mention is that perhaps one of the hottest button issues in respiratory management is the need of a tracheostomy tube. And I feel very strongly that the only absolute indication for needing a tracheostomy tube is an airway issue, meaning an airway that cannot be maintained without an artificial airway. Requiring ventilation during both nighttime and daytime is not an indication for a tracheostomy tube. However, some people may choose a tracheostomy tube as a matter of quality of life and ease of care in situations like that. So I will finish here and stop sharing my screen and turn this over to the next speaker.
Fantastic, thank you. Dr. Sarkozy? Mark, tech support, are you able to pull up Dr. Sarkozy?
Yep, she's should be available there.
She's raising her hand.
Okay, hang on. We'll get her here.
Okay.
Hi, can you hear me?
Yes, we can hear you.
Sorry, I have a major problem with connection in my house. My whole internet went down. So I'm currently connected with my phone. So I lost my presentation and I don't know how long this connection will resist. I'm really sorry about this. So I will not be able to show you my slides. It's okay, I can quickly just talk through it. And perhaps I'm happy to put the slides up there as a PDF with share later on with if people want to look at them.
That's perfect. And now with your internet, if you were able to email it, I probably could share the slides.
Yes, that's okay. So I would just very quickly, I'm really sorry because I couldn't hear or listen to anything because I literally just came back into connection 2 minutes ago. So I just saw the last slides of the previous speaker. So apologies for this. So I don't know whether it has already been said or not. Okay. But I would just I believe that we heard about cardiac and respiratory care. So I will talk about the remaining aspects of care for titinopathies. So one of the things I wanted to highlight as the first point of in my part was the importance of a multidisciplinary care. And despite the fact that there are no standards of care available specifically for Titin myopathies, there are a lot of additional efforts that have been done for other conditions which overlap either with the congenital form of titinopathy or the later onset muscular dystrophies. And these standards of care are available and are published on different websites like TreatMD, but also on advocacy group sites, and also translated in different languages. And these standards of care are very important because, as you might have heard in the first talk today about trial readiness, these create really a similar level for all patients and families for care, and it could be very important also to lobbying with care providers and for introduction of trials and new therapies. And these standards of care are really, their inputs are aligned according to the disease progression and that different stages of life. So this care has to be holistic, and in addition to respiratory and cardiac care, has to include different aspects of the care of patients. And probably the first and most important part is genetic diagnosis. And I strongly believe that really that is the first moment of care for patients. Make sure that everybody has access to genetic diagnosis, which is the gold standard for diagnosis. And although titinopathy, Titin diagnosis is quite challenging, and there are a relevant number of patients who might not have yet a genetic diagnosis, it's something that we all need to try to achieve and try to obtain for patients. And clinical and muscle biopsy investigation could support diagnosis, but are not fully sufficient. And this is important, genetic diagnosis for future planning, prognosis, genetic counseling, and to participate in possible trials in the future. But in addition to genetic diagnosis, at moment of diagnosis, it's important to also offer families and patients a lot of other inputs as well, give them time to answer questions, to understand the condition, and provide families with information linking to resources, advocacy groups, fact sheets, information, and give information which are relevant for the families and are reliable. And it's important to also refer to genetic counseling after diagnosis. It's also important to strive from the beginning to arrange neuromuscular follow-up for patients. And we advocate for follow-ups that should be with a neuromuscular specialist who's expert in the condition at regular intervals that should be according to the age and phase of the disease, and might be more frequent in a younger child and less frequent in older individuals where condition might be less progressive, with clinical assessment, examining the child or the adult patient with in all aspects of general clinical examination. Do respiratory assessment. We do, for example, spirometry for patients in clinic, and leading more detailed respiratory assessment for the respiratory consultant. Do standard physiotherapy assessments with time measurements, goniometry, functional motor scales. And the neuromuscular doctor really becomes also a coordinator with all the other specialists. So make sure that every aspect of the care are looked after. And it is important to discuss interventions with the physiotherapist and occupational therapist, stretching, splinting, orthosis, standing devices, adaptive technology when needed. And it's also important that exercise is considered. The exercise is very important, and moderate symmetric aerobic exercise is likely non-harmful, actually could be helpful, like swimming is very good exercise. And actually resistant exercise is probably less beneficial and usually not recommended in any type of muscle conditions. Now, in terms of pharmacological intervention, there are no treatments, no cures for muscle weakness or muscle problems. Apart from the only drug that we actually give in clinic is vitamin D. Make sure that nobody is low in vitamin D, but otherwise no other natural remedies are recommended. And actually, I always highlight the attention of families that while we don't, there's nothing that we say is natural remedies might be harmful, but some of these products might be exclusion criteria for studies. So it's very important that you consider you take some drugs that might then exclude a family from a study. And steroids are not used in this form of myopathy. Other limb-girdle muscular dystrophies might have tried steroids, but not in titinopathy, and there are different pathomechanisms. Clearly, orthopedic inputs are important, and it's very important that if there's surgery is needed, this is very carefully planned with the respiratory and cardiac consultant. Discuss, it has to be done by an experienced surgeon, and there has to be careful preparation before and after surgery so that everything is taken care of. Nutrition is key. A lot of people with titinopathy might have problems with feeding. That could be up to 50% of patients, and low weight could also affect respiratory and cardiac functions. It's important to make preparatory interventions for that. And finally, the last point I wanted to raise was the fact that intervention needs to consider prediction of changes. So think ahead of possible deteriorations and make sure that the individual with the titinopathy and the families are ready for the change, to make sure that adaptations and intervention are in place. I also would like to raise the fact that this condition can often associate with fatigue. And this is something that has to be considered. It could be confounded by respiratory and cardiac factors and pain. And we don't know yet how much is this related to postural problems, but this is something that has to be considered. So I think it's important to keep fatigue and pain and look after, ask about this in clinic and treat if possible. As interesting, in other forms of central nuclear myopathies, fatigability is observed, and some treatments have been followed for patients with fatigability, but not with, we don't have experience yet with titinopathy. And that was the last few things I wanted to say. In my slides at the end, I also offered link with all the charities and advocacy groups looking after people with titinopathies or central nuclear myopathies. And I believe that, Sarah, you also shared some of these links in your presentation in the chat box. I'm so sorry I couldn't share the slides, but as I said, I will make them available.
Thank you, Dr. Sarkozy. Very adaptable by swapping to the phone. We appreciate that. And we're really glad that we're really able to hear your presentation, and that's important. So I just wanted to thank you, everyone, all the speakers. I wanted to point, if you look at the bottom of your screen, there's a button that says chat, and it looks like a quote. If you touch on that and the screen pops up and you can see there's a couple of PDF guides, you should be able to touch on them to download them. If you have any technical difficulty, there's one for limb-girdle, one for the congenital myopathy family guide, and then a titinopathy fact sheet. But if you have any difficulty, they're also on the Cure CMD website. So, and they're on the Titin myopathy website as well. But we have kind of congregated a lot of our care guides onto the Cure CMD website for people to refer. And by the way, they are translated into a few different languages. So it depends on the guide, but you can check that out there. So I just want to, so we are at time. So if it's been our 40-minute session, if speakers or attendees, if you need to leave, I invite you to leave now. If you are able to stay for a few minutes, we could have posed some questions either in the chat or Mark, tech support, if you could unmute people. Yeah, thank you very much to all our speakers. I'm extremely appreciative, grateful, and so great to hear about these care tips, because we all want a treatment for tomorrow, but in the meantime, we really need the best treatment for today. So if you have a question, you can pop it in the chat. If you have, if you want to unmute yourself to speak, we could do that now.
Yep, they can do that now.
Okay, thank you, Mark. I appreciate that. The last thing I wanted to mention is this session wraps up. We still can, if you'd like, to go to the portal and hop into the lounge for people connecting with each other that way and chatting. So that's an option. And then also just be aware that the sessions will be recorded and available inside of the portal through the end of August. Not immediately. You got to give us some time to get them together and organized and up on the portal. But just be aware, because I know for myself, I need to listen to information a number of times to really kind of sink it in. So just want to thank everyone for coming. Do you have questions? Okay, so there's a question in the chat to Dr. McNally. Dr. McNally, what are the main factors that you decide within those ranges of frequency for cardiac tests?
Yeah, mostly has to do with whether they're normal at baseline. So usually you start in the beginning, and if things look really, really, really totally normal, then it's on the longer end of that frequency. And if things look subtly abnormal, then we'll usually move up that frequency.
Thank you, sounds great. Other questions? People want to say something or just put something in the chat? Just give it a moment, and if not, we'll end the session. There's a question about a geographical center of care, optimal care centers in the US. Any recommendations?
I'll just jump in on that because, you know, it can be challenging to travel to places. I would say right now, one of the good things that has happened in pandemic is we all know that telehealth has now become part of our landscape. And with that, video visits are now very possible. So there are many great places to get care. Often these are in the middle of big cities just because there's big populations there. So I know at Northwestern, we have a really absolutely terrific adult facing Muscular Dystrophy Association clinic where we take care of all types of neuromuscular diseases with full staffing by pulmonary and cardiology, as well as lots of support systems. So we have adapted to being able to provide video visits, and but there are many great places around the country that offer good care. And for those of you who may not live so close to something, you can now do that in a virtual visit. And so that's something to take advantage of if that's helpful. And often you'll find that in that context, they'll work with your doctors who are local. It's very important to also have a local doctor that can take care of things that you need.
Thank you for that answer. I think this next question might be answered by Dr. Sarkozy, which is there have been recent studies that weekly doses of prednisone have helped individuals with limb-girdle muscular dystrophy 2J. Would taking this drug possibly exclude an individual from future clinical trials?
So I looked into this before, and I'm not aware of a study for 2J. I'm aware of steroids being used in other type of limb-girdle muscular dystrophies, like dysphelinopathy, or clearly in dystroglycanopathies has been used, dysphelinopathies, but not in 2J. It might be trialed, but this is something that I'm not experienced with. Generally, steroids are used in conditions where there is also an inflammatory component. Like for example, dystrophinopathy, or for example, that has been also used in lamin AC related muscular dystrophies. Clearly, if somebody was on a drug like steroids longer term, this might become an exclusion criteria for a study. However, you could do a washout period where you sort of wait a few months before starting a possible study. So that's might not be a lifelong exclusion.
I'd like to weigh in on that because I'm one of the co-authors on that study that was done in limb-girdle muscular dystrophy. So we had started doing studies in mouse models looking at once weekly dosing of prednisone. And I think that's what the question is about, which is about weekly dosing. And we found actually remarkable efficacy of this once weekly dosing in several different limb-girdle models, mouse models. So we did a small basket trial of 20 patients across the limb-girdle spectrum, one BMD patient, a fairly high number of LGMD2A patients because we happened to, that advertisement went out on their website. And so we got a lot of those. We did not, I think we had one Titin patient in that as well. The high level is we did an open label 6-month trial once weekly, with a primary goal of looking at, is it safe? And it looked like it was very safe. We had some secondary endpoints for improved function, and we did see some improvement, some suggestive improvement of function. So the good news is it's safe. We hope to do a little bit more to look at it going forward. Once weekly is a very different dosing of steroids, and we would hope that that would not be an exclusion criteria for anybody participating in a clinical trial. If we look at the Duchenne situation, as long as you're on a stable dose of steroids, that has enabled participation in clinical trials. But stay tuned, more to come on that.
Wow, it's great that we have your expertise on that. Thank you for chiming in. Another question is, well, whoever wants to answer this is fine. It's what are the best forms of exercise for an individual with cardiomyopathy and skeletal myopathy, but ambulatory?
I'll let Dr. Sarkozy also weigh in. You know, from the cardiac standpoint, I like to recommend things that where, you know, we get some circulatory action going on. So some increase in heart rate. I do encourage people to wear a heart rate monitor. Usually, you know, again, I don't want to give specific advice here, but I like to know what somebody's peak heart rate is. And then we make a recommendation for a peak heart rate to try to attain and hold for as long as can be done. And then we usually recommend a ramp up period and a cool down period, but it usually takes some time to adapt. So the short answer is hopefully your doctor can provide some specific advice how to do that. There are a variety of activities that can be done. And then I'll let Dr. Sarkozy comment about the specifics on the muscle side of that.
Yeah, so generally we encourage activities that are gentle, that are symmetric, and we have to consider that in addition to muscle weakness, there's also the component of the joint contractures or hypermobility that might be present. So it has to be something that does not put, for example, or in an extension, so we don't increase the contractures in the joints. And also no activity against resistance, because that might be harmful for the muscle. So the goal is not to increase strength, but to maintain strength in a gentle way and keeping active. So doing a little bit every day and not a lot randomly.
Those are great tips. Thank you for weighing in on that issue. Exercise is a very common question from families, so thank you.
And then actually there's a lot of, sorry, just to add in on that, there are some research centers, just thinking, for example, the group in Denmark that are looking into exercise and benefits of exercise in different types of muscle conditions. So, I mean, it's definitely something that is important, and often pain is improved when you do regular exercise to keep muscles in use.
That actually segues perfectly to the next question, and maybe Dr. Sarkozy, if that might go to you, which is, my muscular doctor told me that I shouldn't be in pain, but I am. Any recommendations to cope with pain? And it keeps, you know, keeps people from doing their daily activities.
Well, I guess this is somebody who has titinopathy, but I mean, in general, we have to understand why pain is there. So what is the cause of the pain? I guess that's the most important. If this is considered postural, it has to be looked at why, you know, what is the reason, and if there's any postural adaptation or change that could be made to relieve the pain. So there are a lot of reasons why pain. If it's purely muscular, exercise actually can be helpful. So using muscles often helps to decrease the pain, and being regularly active might prevent also, but it's often postural, and in particular in conditions like titinopathy. So it needs to be discussed also with the physiotherapist and the doctor looking after the person. Thank you.
That's great.
And sorry, may I just ask, just add, but I mean, clearly I'm not advocating too much medications in general, but I mean, if somebody is in pain, you know, painkillers could be taken, but again, has to be discussed with the doctor looking after the person. But painkillers are there, and I think if used in a controlled way and with somebody reviewing the medication, that's something that we have to consider.
Great, thank you. Someone asks, I'm from Italy, maybe you can suggest a center more active than others in Italy regarding research and specifically related to titinopathy.
So I don't know if this was the person I spoke with before. I mean, in Italy, there are a couple of centers who have more major interest in myopathies in particular, both in genetic aspects or clinical aspects. So clearly the center led by Professor Mercuri, or the center Enrico Bertini at the Bambin Gesù are two centers who have a major interest in both the genetic and clinical aspects and care as well in trials for rare neuromuscular conditions. But there are, you know.
Anna, can you just say, Dr. Sarkozy, can you say those names again? I just didn't catch them. Oh, you got that?
So Professor Mercuri, Eugenio Mercuri, who works at the Università La Cattolica in Rome, He's linked with quite a number of centers who are also involved in treatments for muscle conditions, and the other person that there are many others, but is Dr. Enrico Bertini, that works at Ospedale Pediatrico Bambin Gesù in Rome, and who has a major interest in rare early onset forms of myopathies. But there are centers also in Genova and in Tuscany, in Milan. I mean, depends also where the person is asking is located in Italy.
Fantastic, thanks. And I see Dr. McNally put a name in the chat. Thank you for that. Very good. Well, I just am very, very appreciative for all your care guides and advice or outlines today, and I appreciate all the attendees for coming.